Thank you for inviting me. So my talk today probably overlaps the talk with Professor Weiser for some kind of locally advanced treatment. So we are in the same topic. So I would try to. This is the outline of my talk. As we have many trainees here, I'll probably go back to the data that in the past that somebody might not be here yet, like they are not born at the time. So we talk about locally advanced disease and we talk about the proficient MMR. We're not talking about the deficient MMR as Professor Kritiya and Professor Manop talk about the immunotherapy. So we are in the patients with chemotherapy and radiation therapy for locally advanced disease. So first of all, when we talk about locally advanced disease in the past, this is in the year of 1980, when radiation therapy comes to the world of rectal cancer, because we know that in the past, when we add radiation therapy and chemotherapy to surgery, we improved the local regional control and also for the overall survival at the time. And it's 2D for sure at the time for the radiation therapy techniques. So when we moved on into the year of 2000, things changed. We moved from post-operative concurrent chemo radiation therapy to pre-op treatment. And at that time, there were many studies coming to support the data of preoperative concurrent chemo radiation therapy that pre-op, when you compare to the post-op treatment, it improved to the local regional control, improved the sphincter preservation rate, although it's not improving the overall survival comparing to the post-op treatment, but it decreased the GI side effect for sure. So people moved on from post-op to pre-op concurrent chemo radiation therapy as a standard treatment in the year of since 2000. And then when we talk about the pre-op treatments, for me as a radiation oncologist, as Dr. Tapan mentioned a little bit, for a short course radiation therapy, at the time it's not the TNT treatment, but it's pre-op treatment. Mostly the data came from European country. When they used 5 by 5 gray per fraction, 5 daily treatment, we call that as short course radiation therapy, and it's radiation therapy alone. It's not concurrent chemo radiation therapy during the week when they give short course of radiation therapy. And they compare with the conventional long course concurrent chemo radiation therapy for 5 weeks. And for the regular one, we call the regular one for conventional long course chemo radiation therapy. We wait for about 1 or 2 months, and then we go surgery. And we expect that some outcome should be different. The difference is really different. If you give more radiation therapy dose, it's not like compare 25 to 50, but for us, like a biological equivalent, is not equivalent. 50 is more than 25 gray for sure. And you can expect that if you give long course chemo and radiation therapy, you can get higher PCR rate. It's coming like that. So short course radiation therapy might not be suitable for the very bulky or locally advanced disease. However, it's not different in overall oncological outcome. And also for the toxicity, people might concern for 5 by 5 for the toxicity. But in terms of data, there's no difference in the toxicity between short course and long course chemo radiation therapy. So now, what is the problem with pre-operative treatment chemo radiation therapy or even short course radiation therapy? Why the TNT comes to our world? Actually, because if you think about the CR rate, people like to have pathological CR rate after the pre-operative treatment. But we not come to that point because the CR rate is only like 16%. It's not that high, still low. And also for the major pattern of failure, once we treat with radiation therapy and chemotherapy in combination, the local recurrence go down, but the distant metastasis is still high, it's like 30%. So what we are going to do with that? So if we want to improve the the PCR rate, can we do like wait longer? Let the chemo and radiation work, and then wait for the longer time. Is it going to be more to respond more and more after we wait for the longer time? And at that time, during the waiting time, because we know that it's distant metastatic, high rate of distant metastatic for the locally advanced, can we give systemic therapy to to improve our outcome. So this is a concept of total neoadjuvant treatment when you try to do the total neoadjuvant treatment for improve the local regional control and also for the overall survival by decrease the distant metastatic risk. So you can see that the TNT, the total neoadjuvant treatment, can be started with radiation therapy first or start with chemotherapy first. I will go into the detail on that. This is the data of short course and long course TNT treatment compared with the standard at that time, which is concurrent chemo radiation therapy. And for the short course radiation therapy here, they're supported by multiple studies in the Europe, majority in Europe. And then here is 3 landmark trials for short course radiation therapy for TNT. We talk a lot about the Rapido trial, but there are older studies for Polish trial and also for the Asian country study for Stella trial. The results of the TNT as short course, the result is in the same way. We improve the PCR rate by giving TNT because we give chemotherapy after short course of radiation therapy. It's not only short course of radiation therapy, but we give chemo. When you compare with the pre-op chemo radiation and just go to surgery by doing nothing after chemo RT, you get more CR rate by getting TNT treatment. And also in some study, it improved in the distant metastatic free survival, like a Rapido trial, and improve in the overall survival in some trials, like Polish trial, older trial, and improve in overall survival with the new trial, Stella trial. However, this is a problem of Rapido trial, as Professor Weiser talked earlier. I will go just a little bit into detail of the Rapido trial. As a radiation oncologist, we see that, okay, well, it's 5 by 5. Maybe it's a problem of dose of radiation therapy. Or maybe it's because of the included tumor is too bulky disease for 5 by 5. As we said, 5 by 5 is probably not really enough. Even you give chemotherapy, but it might not be enough for the very bulky disease which they include like more than 3 high risk in about 1/3 of the patient in the trial. So it might not be too surprised that why the local regional field is higher, even though the initial PCR rate is higher for the TNT treatments. So it might not be really cut back for the short course because they'll have the other study like Stella try to support TNT with short course radiation therapy. And I will talk that later on the ongoing trial. They still have the ongoing trial for 5 by 5. So here, let's go to the long course chemo radiation therapy for TNT. So here is the data support the TNT for the long course concurrent chemo radiation, not short course anymore, but long course chemo radiation as we practice nowadays. So the Prodigy trial, the first trial, this is a study to support the long course TNT that improved the PCR rate. So the other 2 studies for the German trial and the Opera trial from US, this is not the real supporting for the TNT. We know that TNT is good, but what sequence is better for the TNT, comparing between starting with radiation therapy first or starting with chemotherapy first. So we can expect that if you use radiation therapy first and we wait longer, and during the time of we waiting, we give chemotherapy, it should be better for PCR rate, and the result confirmed that. So here is the summary of the TNT. If you talk about the TNT, I think we not really cut back for short course, but we have to be sure that it's not too bulky to get short course radiation therapy for TNT. And then I think TNT give you more PCR rate, up to 28% for the Prodigy trial. And in my opinion, if the patient is likely to be a little bit bulky, you probably go start with chemo radiation first, and let's wait by giving chemotherapy afterward, like consolidated chemotherapy, and get surgery at the end. So it might be the best scheme, in my opinion, to get TNT at this time. We talk about the neoadjuvant. I'm not touching on the neoadjuvant chemotherapy like Prospect trial or Chinese trial like Fallback or Convert trial. But it's possible, but you have to select it well. It's not like locally advanced. It's not middle to lower rectum as we have now. It should be upper to middle rectum to get neoadjuvant chemotherapy only. And this is go to surgery is It's not like you get everyone can get neoadjuvant chemotherapy, to be cautious on that. So for me, TNT still need radiation therapy, not only chemotherapy if it's locally advanced. So now we talk about TNT already. We are moving more to the non-operative management. What is the problem of TME surgery? So people might feel that, okay, once I got clinical complete response, do still I need the surgery afterward? Because I might not want to do the surgery if they take out the sphincter, and there is no some complications we don't like low anterior resection syndrome, or maybe the potential complication perioperatively. And also it affects their quality of life. So this is concept, is a basic background that the non-operative management is coming to our treatment nowadays. So this is data support for the organs preservation treatment with radiation therapy, not chemotherapy, but radiation therapy in combination with chemotherapy. And again, this is a treatment paradigm. We are in the right-hand side. The nowadays treatment is right-hand side. It's TME treatment, preoperative, TNT, and then go for surgery. And now we're trying to move to on the left-hand side for the organ preservation intended. They're not talking about only locally advanced, but they are go to the early stage disease as well. So here is, if I separate the patient into 3 groups, first group is early stage disease. The second group is locally advanced but non-bulky disease, and the right-hand side is like very bulky disease. So just look at the first one first. You think there's one, it should get surgery, and I agree with that. But if the patient has middle and lower rectum, and they need to do the APR, what are you going to answer the patient? So here is the data. I just put some of the data that's actually so many data coming through for the for the organ preservation in early stage disease. Here's the data. It's not really early stage, but it's early non-bulky disease. They give concurrent chemoradiation therapy first, and if the patient responds well, instead of go for TME, they go for local excision. It might work in about 30% of the patient, not that high, but it's kind of a little bit surprised, not that high to got 30% that they can got local excision. But the problem is a function after local excision. So people might think about like, okay, if they got a good response, can we just do the organ preservation then? So this is one study to support that. So for the second one is locally advanced but non-bulky disease, as we practice as preoperative treatment. This is not really TNT because it's non-bulky disease. A patient might not need consolidated chemotherapy afterward. So let's look here. This is the data of radiation therapy for organ preservation for external beam radiation therapy, and also for endorectal brachytherapy I will show you. So this is a study just come out this year for the STARTEC trial. This is from Netherlands and UK in combination with UK, European study. They do they randomize the patient to get surgery first, and then 5 by 5, again, European country, and long course CCRT. And they evaluate the response. If the patient responds well, they do wash and wait. And this is a new trend of radiation therapy. We're not doing the whole pelvic radiation therapy. They try to do limited by the mesorectal radiation therapy only, but this is N0 patients. So remember, this is clinical N0. But on the real data, when they look at the patient on the TME arm, they found 20% of node positive. So MI is kind of unreliable for nodal evaluation at this moment. We don't have already data for nodal evaluation for preoperatively. So here, if you want to do wash and wait, again, this is a data confirmed that long course CCRT should be better, giving more radiation dose, and then probably chemotherapy as well, to get better outcome for the non-operative management if you want to do the non-operative management. Here's the data. Maybe the aspirin should not work well with this patient, because when after chemoradiation therapy, they do the brachytherapy. Actually, this is not brachytherapy, this is contact. This is not OPERA trial, this is OPERA trial. This is brachytherapy trial. So when after external beam radiation therapy, and you random between external beam boost and contact X-ray boost, they do the applicator into the rectum directly. because you give more radiation to the surface, and then you get a better outcome by the TME-free survival. This is real data confirmed that this is in Europe again, because they are very expert in brachytherapy. So the organ preservation is better when you do brachytherapy, but it comes with price, bleeding, rectal bleeding afterward. Again, this is the study from Canadian study and US study. For the Morpheus trial, this is the same concept as contact brachytherapy, but it's a high dose rate brachytherapy. And again, the same thing. When you give brachytherapy, you got better outcome. And again, more rectal bleeding on that. So this is our experience by Dr. Pitaya and Dr. Tisana for our experience to do the brachytherapy boost to the anterior residual disease, this residual disease and the anterior wall of the rectum. And they do the brachytherapy boost and give radiation more in the front and the anterior wall, and less duration dose at the back of the rectum. So, and I moved to the things for TNT if you want to do the organ preservation. So here is the data of OPERA trial. The OPERA trial is TNT organ preservation trial. So here they do the, as we expect, again, the chemo radiation first, followed by chemotherapy, should be the better regimens to the organ preservation from this study. But to be aware is that it's not 100% good. It's good. It's good. It's the best one. We got the data now, but the regrowth rate is not that good. It's 30% regrowth rate. You have to be aware. You have to be a very intensive follow-up for digital rectal exam, endoscopy, MRI. Because you can see here is drop very fast after you wash it up. The first, actually, second year is very important to follow up. After that, the preservation as TNT, this is German trial. It's just presented, it's just published. They pick up the concurrent chemo radiation therapy, followed by chemo, and do wash and wait. This is phase 2, only one arm. And then the result happened like this. You can see the drop very fast here. Like first year, after first year, people recur, the patients recur. They try to discuss why the result is not as good as of 1%, comparing to the OPERA trial, which go to 50%. And when this is an interesting thing they found. When we evaluate the patient gets a complete response rate at about like 3 months, they 106. But if they wait longer, the patient got CR more and more. So if they combine for the clinical complete response, it's about 37%. And at the then the patient got immediate surgery. The patient had pathological CR is about like 20-something%. So it might not be inferior to OPERA trial, but they evaluate at the different things. So here is the last one. The very bulky disease, is this patient suitable for non-operative management? I doubt that. But there are ongoing studies try to address these questions for the organ preservation for the very bulky, locally advanced disease. They do the doublet and triplet chemotherapy in combination with radiation therapy. This is our ongoing study. And here is the data. You can see here, they're not give up for 5x5 to do the non-operative management for the bulky disease. And I can expect that what going to be an outcome. The lower one should be better for sure, as we expect from the previous study. So in summary, here's my summary for the organ preservation nowadays. It's not organ preservation. We are in the era of TNT, but it's possible to do the organ preservation. And here, I'm sorry. So if you want to do the organ preservation, I think, as I said, CCRT followed by chemotherapy should be the best regimen. Actually, we start from TNT first, and we evaluate the response if the patient is suitable for organ preservation or not. And so this is the data that it's possible, but it has to be very cautious, even especially during the first couple of years of the treatment. Thank you very much for your attention.
Thank you very much, Professor Chantila. Any question from the floor? Yeah.
What do you think about, are there any roles for short-cut RT in locally advanced rectal cancer? Do you think that we should not use it anymore? Because if there were the big tumors, so we use the concurrent chemo RT followed by the chemotherapy. But with the middle rectum and it's not big, so we just use the chemotherapy alone, just like the prospect try. So are there any room for the shortcut RT nowadays?
This question, let me ask Dr. Joe. For me, aspiration causes, and Dr. Kritiya as well, Dr. Sushini as well. So I think 5x5, we not really concerned for the side effect during treatment. Now, because we're moving to the advanced ration technique, we decrease the dose to the bowel, to the bladder. The patient tolerate ration quite well. They never come back to me like very bad abdominal pain. But our data now, the 5x5 is not as good as we expect. And also for the complication that Dr. Joe discussed for the complication during the surgery.
Yes, because 5x5 is good for patient. Because the patient come to the hospital just only 5 days compared to the 28 session or something like that. Therefore, when our colleague asked us to change from the long course to short course, we totally agree with them because it's good for patient, it's good for the queue of the radiation. However, when we pass like 8 or 9 months, start 5x5 and give a consolidation chemo, the case come back to the operating room. And that is the time that we realize that it's very hard to surgery. For the long course, like a long course and consolidation chemo and do surgery, we are okay because we operate at that situation all the times and we can do the surgery well. However, for the short course and we give consolidation and surgery, it's very tough situation in our operating theater. Not only me, but our colleague in the colorectal unit as well. Marty, do you have a comment?
Yeah, we have very little experience with short course except during COVID when we switched completely to short course. And our small experience shows, as we would expect, there's a lower rate of rectal preservation. And in our population, that's very important. So although we were excited, as Joe said, because it's so much easier, we moved away from it. The other place we used short course a lot was stage 4 disease. But in that population, we often want to perform or we want to avoid rectal surgery. So we now incorporate more and more long course chemoradiation, as you described, because it does, again, give us the best chance of avoiding rectal surgery, which I think is important in stage 4 patients who will likely be on chemotherapy for the rest of their lives.
One more question. Yeah.
Thank you. For those patients who did not achieve clinical remission, remission on the second phase, those in the second stage, for those receive total neoadjuvant therapy compared to traditional CCRT, then followed by surgery, are there any difference in the complication rates in post-operation, like in compared to those who receive TNT? Then did not achieve CR and then surgery, compared to those received traditional CCRT then surgery. Are there any complication rates between those groups?
You mean complication during
Post-op surgeries, like?
It's just the same. Yeah, it's just the same from the study. Even you give the time and the consolidation chemo did not change the complication after surgery. Therefore, we move our surgery to after the TNT safely.
Yes, I would agree with that. I just one comment. We are very excited about contact radiation, and we hope to start that soon. we do have a similar probe that you have that we've been giving brachytherapy to select patients. But I think it's, I do think the Papillon technique has been used for obviously quite a long time with excellent results. It's very interesting. I've always been concerned about the lymph nodes, and as you had mentioned, preoperative staging is not very good with at least 10 to 30% risk of positive lymph nodes, even with a negative scan. But it seems to be okay, which is interesting.
Yeah, but I think we should start with external beam radiation therapy first and do the brachytherapy boost. That should be the best way. It's not going to be the brachytherapy alone. And then for the lymph node, I think if we're not seeing the gross disease, we just do like microscopic dose of radiation therapy, like 50.4 gray should be fine. But if we see the lateral lymph node or node that we want to boost, we just boost it to higher than like 50.4. We go to 54 or 56 gray sometimes. So I don't think there's going to be a problem for the lateral lymph node. We can have the sessions after this, but the brachytherapy should be after external beams, not brachytherapy alone. So the lymph node should be fine.
Yes, yeah, we would definitely use it afterward as a consolidation, but that's a very good point. The micro metastases in the lymph nodes will be more sensitive to the external beam.
Yes, thank you very much, Professor Chanchila, and she's still with us until the discussion. Yeah. And the next topic again is like a back and forth again, because if we go back like 10 or 15 years ago, not a lot of us believe in HIPEC. There is just a very small surgeon believe in that situation, like a sugar baker in US or some Asian or German surgeon believe in HIPEC. But nowadays it seems that the HIPEC become more popular again. Therefore today we have Professor Asada Metaset. He is our boss and also the one of the most experienced HIPEC in Thailand. Professor Asada, please.
Thank you, Professor Atapon and Professor Vichun, for inviting me for this lecture. So my